Good afternoon and welcome to the Department of Behavioral Health COVID Update, our weekly report out on where we're at. All right, this month is Women's History Month. I hope you've seen the video that's been put out by our Public Behavioral Health Department. Throughout the month, we'll be featuring women in behavioral health. And so stay tuned to that. I liked watching the video, Dale and Dr. White, and I hope you are enjoying that too. All right, by the numbers, 115 million cases of COVID worldwide with over 2.5 million deaths recorded. In the United States, just under 29 million cases and almost 520,000 deaths from COVID. We were talking this week, it's been almost 1 year since we declared a state of emergency in Fresno County. I believe that the pandemic was declared by the World Health Organization on March 11th of last year. And at that time, we would have probably not believed that it would have lasted a year, nor that we would have over 500,000 deaths in the United States. In California, we have almost 3.5 million cases and just over 53,000 deaths. And our positivity rate is now down to 2.1%. So we're continuing to decline. That's very, very positive for us. Those variants are still out there, but for now, our numbers continue to go down. In Fresno County, we're just under 96,000 cases at 95,893 and 1,458 deaths. So about 57 deaths since last time we reported. In terms of hospitalization, big decline, down to 174 hospitalized, 35 in the ICU, and now over 24 ICU beds. So if you look on the right-hand side, you can see that we've really went down. We're almost half of what we were just under a month ago in the hospital. So those are really, really positive, light at the end of the tunnel kind of metrics. In terms of the tier system for reopening, we now are solidly in the red for positivity rate at 6.0, and of note, we're under for the health equity metric test. So remember, this is our lowest socioeconomic census tracts. We look at the positivity rate there, and it needs to be at a certain amount, or we kind of get penalized in this tracking. However, new COVID cases per 100,000 remain above 7, which is our purple tier threshold. We're down to 14 though, and I believe with 14, outdoor youth sports are allowed. And we are declining still. So if you look at the right-hand table, really, really declined since January, where we were at 75 cases per 100,000. But we need to keep going down if we want to get in the red. So if next week we're under 7, cross your fingers, say a prayer, we'll need to be in the red for that metric along with positivity for 2 weeks to actually exit the purple tier and be declared into the red tier. So just a reminder, you have to be in a tier for 2 weeks before you stay in that tier. Vaccine update from the state's website, 191,571 vaccines have been delivered in Fresno County. In terms of the Fresno County metric, this is from a few days ago, so remember this information lags what I just showed you. When we had delivered 171,000 doses, that represented just under 42,000 residents who are partially vaccinated and 33,573 who are fully vaccinated. And so about 7.7% of the population has been vaccinated. All right. Johnson & Johnson was approved. We anticipated that last week. This is really, really good news for us. Remember, this is the single-dose vaccine. We should get doses in Fresno County as early as next week in terms of being able to deliver them. The people who we serve in our department, as well as persons experiencing homelessness, will be prioritized for the Johnson & Johnson vaccine because it is a 1 dose. Likely how we will accomplish that is through a combination of what we call open and closed clinics. So an open clinic is what we've had, for instance, at the fairgrounds, where anyone in the general public who fits a tier can come there. And the closed clinic is what we had at Pathways, the one that most of us got vaccinated at, where only people in a particular tier can receive vaccinations. So if we reopen that clinic, it would only be for persons who we are serving. And so we'll likely do that. And then eventually we hope to simply have vaccine on hand with our medical teams to administer vaccine whenever anyone comes in for treatment and is eligible to receive the vaccine and has not received it yet. So we'll be putting that plan together in terms of whether or not we will have a closed clinic, and if so, when that will occur and how long that will go on, and we'll be communicating that as we get more information. Additionally, President Biden announced that with arrangements made through the federal government, they anticipate that there will be enough vaccine to vaccinate everyone in the United States by the end of May. So again, cross your fingers, say a prayer, and let's hope that that really does happen. And that's largely driven by an agreement that the organization called Merck, which is another drug manufacturer, has made with Johnson & Johnson to assist them with manufacturing their vaccine. And so that will greatly increase the capacity to produce the Johnson & Johnson vaccine. All right, so I teased this last week. When will the pandemic be over? Or when will we know that the pandemic will be over? So you're going to get a little more teaching today. I hope you can tolerate that. I have a lot of slides, but I'm going to try to be really, really quick. One thing I really want to emphasize is the risk of a pandemic of any sort will remain high for the world for some time to come, maybe forever. I don't know. But when I was doing a little bit of research to do this presentation, pre-pandemic, there were a number of articles warning that there was a risk of a pandemic, and sure enough, we got COVID. So there are millions of viruses that already exist, and the likelihood that one will make the jump to humans is always there. Most viruses and a lot of bacterium and other types of diseases come from the environment, either unclean water or spores in soil and such, or from another animal. We have bird flu, avian flu, we've had swine flu from pigs, and it's believed that a rodent of some sort or a bat is where we got COVID. In fact, the bat's kind of the leading contender. And so basically what happens with viruses is they may make that jump back and forth over many, many years. But if the person who gets it is isolated, maybe they don't get too sick, or they die from it and never pass it on, then that jump got made, but it doesn't get entrenched in the population. And every once in a while, though, it does. And so as time passes, the chance that that could happen also goes up. And it allows that virus to mutate, make it easier to get into a human, or just having more contacts. The other thing is we have a lot more density in the world today. There's just a lot more people and a lot more highly populated places, so a lot bigger chance that you could spread it from one person to another. And then we do a lot more travel. Our world is much more connected than it used to be. And so that chance that a localized virus will become regional or worldwide in nature is even higher, particularly with the different properties of viruses and how easy they are to transmit and how transmissible they are before you have symptoms and how quickly those symptoms would incapacitate you. So in terms of diseases that we have, what diseases have actually been eliminated or what we call eradicated? When you hear eradicated, it's basically there's no incident of that occurring across the world for a certain period of time. And eliminated means that you've largely decreased it to the point that it's not really even epidemic proportions. And really, the only one we have is smallpox. And smallpox is considered eradicated. It is from the variola virus. Smallpox has been around for thousands of years. It's been killing people for thousands of years. The first known case was in the 3rd century. We only know that because it was detected in mummified remains. When it was prevalent, it kills upwards of 30% or more of the people who get infected with it. There's two strains, a major and a minor. The major is much more deadly, with an even higher percentage of babies who died from it. In the 20th century, 300 million people died of smallpox, and over 500 million people in the last 100 years of its existence. And those who survived were left with really extensive scarring and blindness. Just like COVID, airborne transmission, and some through contact with contaminated objects. Unlike COVID, infectious only when it's symptomatic, often occurred in outbreaks. And they began inoculating as early as the 10th century in China, using the variola minor, the least deadly of the variation of smallpox. They would give people a small amount, they would acquire smallpox and then become immune to it. And it was much less deadly that way than it was if you got it naturally. The modern smallpox vaccine was developed in 1796. And the World Health Organization really intensified efforts to eradicate it with large smallpox vaccination efforts across the world. And it was so effective that by 1972, routinely smallpox vaccinations stopped being given. People in my age range are some of the last to have gotten smallpox vaccine. And because it was like an abrasion given on your skin, you have a very distinctive scar from getting smallpox vaccine. The last known case was in 1977, and by 1980 it was considered eradicated. So we're not really that good at eradicating entirely viruses or bacterium or that type of disease. We have some that are on the road. Polio has largely been eliminated through vaccination. A disease called guinea worm disease really was eradicated through clean drinking water efforts across some of the underdeveloped nations in the world. And then measles, mumps, and rubella was very common even when I was a kid, and those vaccinations are ongoing today in order to eradicate those or eliminate them. There's been a lot of anti-vaccine proponents who have compromised these abilities to eradicate these diseases. I think sometimes people forget that some of these diseases can not just be deadly, but they can also cause long-term scarring and other debilitations, like with polio. I know when I came back to California from living in New York and was working at San Joaquin Valley Rehab, one of my colleagues, actually two of my colleagues there who were just a little older than me, who were didn't get the polio vaccine when they were a kid, both had gotten polio and had significant disability because of polio. So one of the things we're challenged with, and we're seeing it with COVID as well, is vaccine hesitation, or a belief that vaccines are worse for you than getting the disease that the vaccine is trying to prevent. So that's a challenge for us. And when we eradicate these either deadly or debilitating diseases, it's easy for us to forget that there can be those types of consequences. All right, so with COVID, what would we look at to determine whether or not the pandemic was over? And it's important to talk about, remember, an epidemic is different than a pandemic. A pandemic is when a disease is widespread across the world and really at that point almost impossible to control. And so we get outbreaks of the flu every year. You might even call it an epidemic, but we've learned to live with the flu. And so we anticipate that we are not going to eradicate COVID, at least not until they develop a different type of vaccine, which they are working on. But we're probably not going to eradicate COVID. So how do we get the incidence of COVID to an acceptable level? And so a lot of the experts kind of compare it to the flu in terms of we've learned to live with the flu. What's the incidence and fatality rates of the flu that we've all come to accept? We don't wear masks and wash our hands more than what you might always do during flu season. We talk about it. We tell people, to get the flu vaccine, but we don't shut businesses down. We don't take those types of drastic measures. And so What's that level of incidence that we could find acceptable? So one thing we look at is positivity rate. And a lot of these things are things that are in those tier systems. And so typically 1% or less is usually given as a measure of a virus being under control. So at a level that it's not going to disrupt society. And currently, as I reported on earlier, in California at least we're at 2.1. That's not the case worldwide, but that's the type of percentage we need to be reaching for, is that 1%. And then there's case rate. And if you'll recall, for our lowest case rate, it's in the lowest tier, it's one new case per 100,000 people. And so for the United States as a whole, that's 3,300 cases per day. And right now we're at 50 to 60,000 cases per day. So we have a little ways to go before we would get down to that case rate. And remember, in Fresno County, it's 14 right now. 14 cases per 100,000 people is what we're at. And so even to get to that rate in Fresno County, we have a ways to go. I don't think we've been there for a long, long time. Okay, death rate. Generally, experts say no more than 100 people per day across the United States should be dying of COVID. With flu, it's 55 to 140. So about 100 is where you're making that comparison with flu, saying, well, we've come to accept that. We know people die of the flu every year. Regularly, up to 140 per day. So if we got COVID down to 100, we could treat it more like the flu. But currently we're at 1,989 a day. And 474 is the lowest since we started tracking it with the pandemic, once people started dying. And so, we're pretty far off of that. And when people constantly make those flu comparisons, this is a good example of why that's probably not really a comparable thing. And so then it's vaccination rate. How do we get to these other numbers is we need that herd immunity. And remember, the only ways to get herd immunity are to vaccinate, where we develop our own immunity through the vaccination process, or by getting COVID. And when you have COVID, you have some level of immunity afterwards. We're still not exactly sure exactly how long. Right now, they're saying at least 90 days. We don't know how much that drops off after 90 days. Do you keep some level of immunity? Those are things we're only going to know after time. And same with vaccinations. Will we have to have booster shots like the flu vaccine, or even some of the other types of vaccinations that I talked about earlier need a booster vaccine? And so basically most experts say you need 70 to 80% immunity to reach herd immunity and really get to that point that you don't have that incidence of disease and death that starts to shut the economy down. And maybe a higher even immunity in an older population. So remember, individuals in nursing homes were one of the first to get vaccinated because they have the highest death rate. And so that really, them getting vaccinated helps bring that death rate way down. And so you need 70 to 80%. Some say even as low as 60%, but somewhere around 70 to 80. In Fresno, I just reported we have 7.7% vaccinated, so we have a ways to go. But recovered persons also contribute. Again, people who've had COVID. The CDC, I said earlier, something like 28 million people have had COVID across the world, but really the CDC, or across the United States, really the CDC estimates that's probably closer to 80 million. And so known COVID versus the number of people who perhaps had COVID and never knew they had COVID, didn't attribute their symptoms to COVID, or never had any symptoms, you probably could think three-ish to so times higher than what's been reported. And so that's another way to get us to that herd immunity. But those are the types of things. We've also talked about hospitalization in the past. And hospitalization is less, I think, a measure of the pandemic being over or not over, but more like a canary in the coal mine, the type of thing that would tell us, if we're not testing as much, if we're not paying attention, but our capacity starts to go down, that would be another metric that would concern us. And so Mostly we looked at ICU capacity in this last surge, but it's some combination of staffing, beds, and equipment. Early in the pandemic, if you'll recall, real focus on ventilators, at times different focuses on types of treatment and ability to get that treatment. But also then we had a lot of staff who were getting COVID, and that would effectively reduce capacity. Many of those staff have at least had the opportunity, if not gotten vaccinated, so we're seeing much lower incidence of staff in hospitals being unavailable to work because of COVID. And so all of that contributes to more beds. The other thing I'll note is over the last week or two, we've seen a significant decline in deaths in the population in nursing homes. And that really is being attributed to that early vaccination, because vaccination started in nursing homes really in mid to late December, right after the first vaccine, Pfizer, got approved. So those are the types of things we'll be looking at. And really they're the similar types of things that we've talked about in terms of when will we come back to work, because I always get that question. We will start to do more work as a department on what that would look like when we come back to work, what types of measures would we have in place in terms of wearing masks, or how many people could be in a room, or what type of air handling or filters or devices we would use. And so there's still some work to be done with that. We are in March, and we keep talking about our emergency order being through March. That's something we'll be watching closely, and we will continue to communicate with you about what that means and how it could impact us. But again, telework is going to continue for some time. And let me tell you this too. So let's say the emergency order ended abruptly at the end of March, and we were watching it closely, and it just happened. That doesn't mean like April 1st we're all coming back to work. That just means that you know, the work of coming back to work can really commence. I don't anticipate what I would call a turnkey situation. I don't anticipate we say on Monday, everyone comes back to work. I think we'll go through a process where we'll analyze what do we need to put in place, what can we make work, what maybe isn't going to work for right now or some time, and all of that will involve a lot of communication with all of you. And so I would ask you to trust me that we're not going to do something rashly or without a fair amount of preparation and analysis and communication with you. And keep getting tested. I can't emphasize this enough. Remember, one thing we're looking at is case rate and positivity. And if people stop getting tested, that we can't rely on those measures. They're not accurate. And then we would have to rely on hospitalization and death to tell us that there's a prevalence of COVID in our community that we lost track of because people just stopped getting tested. Even if you've been vaccinated, if you develop symptoms, you should get tested. Remember, vaccination doesn't necessarily protect you from getting COVID. You could still get COVID. You're just less likely to be hospitalized, have symptoms, or die of COVID. All right, I'm going to see if there's any questions. I don't see any questions via the chat, and I don't see any questions via text. So I'm getting really good at this, or there's not many people watching, or they just don't have any questions. If you end up watching this as a recording, feel free, if any questions emerge through your listening, to email myself or Tina Young, and we will be happy to get you answers. Stay safe, wear your masks, get tested, and get vaccinated if you haven't already been vaccinated. Have a great weekend, and I will see you next week.